Hi, this is Dr. John Martin, Chief Medical Officer of Butterfly Network, and I want to invite you, and happy to invite you to another edition of our webinar. We've been very active in performing these webinars to share the knowledge and expertise of tremendously talented physicians from all over the country and all over the world. And tonight is no different. We're joined by three fantastic physicians who look at the resurgence of COVID-19 from three different perspectives. It's an interesting title. It may have caught you a bit off guard. I don't think the COVID-19 resurgence comes as any great surprise to anyone as we've looked at statistics, which we'll cover in some length tonight. But maybe you're kind of questioning, challenging the status quo. And what we're trying to do in tonight's webinar is challenge you to think about how are you managing COVID-19 now? What lessons we are learning from those places that faced a great resurgence before now, and some of the dogma that exists in medicine today. We're going to have these three great physicians. Two are with us so far. One is running across from the COVID battlefields as we speak, and Jose will come on board. I'd like to take this opportunity to thank you from Butterfly for joining us, and we look forward to you participating in this webinar. You will see there's a Q&A function that it's part of the Zoom meeting. Please utilize that with your questions. We want this to be a dialogue. It's certainly going to be amongst these esteemed physicians, and we'd like you to be an active participant in that. So I'd like to turn it over to the physicians to introduce themselves, and I'll start with you, Chelsea, if you'd like to introduce yourself and where you are and share some information about you for our audience so they can get to know you as we have.
Great, thank you. Good afternoon. Thank you for having us, John. My name is Chelsea Bergen. I'm family medicine board certified physician, born and raised in Calgary, Alberta, moved to the South, married a Southern boy, they don't move. And I'm privileged to be here. I have taught our med students at the University of South Carolina first year's skills for about the past 7 years. And it was several years ago, we were working on getting it totally integrated into the system for our students for the through 4 years. And it was at that point where I realized, ooh, I need to get on board if I don't want to be behind the times with my first year med students. And so I started learning along with them. And as time went on and I got some great mentors through our emergency medicine physician group, I was able to really fall in love with ultrasound and what it has to offer our patients. So I hung out with a bunch of our local training groups, and then I went for a getaway beginners and advanced course on ultrasound, and now I have the privilege of bringing it into our health system's urgent care we call MD360. So it's been a fun uphill learning adventure to try and teach my colleagues not previously exposed to ultrasound other than that quick OB couple-minute scan in residency. So I love it. It's been a lot of fun. It's been a challenge. I've learned a lot, and I'm excited about this webinar.
That's great, Chelsea. And it's going to be interesting to talk about training and how it impacts other sites actually bringing up ultrasound. Ray, why don't you share your experience, and then you can introduce your partner in crime who has now joined us.
Sure. I guess I'm unmuted. Welcome, everybody. It's a pleasure to be here. I'm Ray Stainback, and I practice general cardiology actually down here in Houston, Texas. And I was recruited here 24 years ago to help head up the echocardiography lab at the Texas Heart Institute. I was at UC San Francisco at the time. And so I'm part of a cardiology fellowship training program and also in practice in a tertiary care facility. And my main focus is cardiac ultrasound. And we've been involved in using handheld devices and point of care ultrasound for several years, but I have to say it's really been mainly looking at the heart. This COVID epidemic, especially in the spring, has prompted us to take a more organized, systematic approach and really work hand in hand more with our critical care doctors. And Jose Diaz Gomez, who's on this conference, is one of those. He's heading up this from the critical care standpoint. He's an anesthesiologist. And so what I've really learned is that not only is ultrasound good for the heart, but really what the focus of this talk is the lung exam. And so that's something that I'm learning. The COVID epidemic is really going to move us forward as far as trying to integrate lung and cardiac findings really much more quickly than what we've done in the past. And with that, I'll turn it over to Jose.
Thank you for this invite. My name is Jose Diaz Gomez. I have the honor to work with Dr. Ray Stainback, and as he mentioned, I think our institution here at Baylor St. Luke's in Houston, through this pandemic, has been able to support us in a meaningful way. And for me, it's a real pleasure to have the ultrasonography as that tool that actually is allowing me to build bridges with cardiology. So I will make emphasis on the utilization with integrated cardiac and lung ultrasound, and that's the reason my relationship with Dr. Steinbach is just every week is better and better. He's an expert in cardiac sonography, and although I love cardiac sonography, just bringing lung ultrasonography to him just make us better clinicians. So I'm really, really excited with this opportunity for the webinar.
You know, I love to see the collaboration between specialties. So often we get in our own silos. And this is one of the interesting things I've seen now across the globe, is the ability for all of us to work across different lines as we do this. And so I think this is a really key part of this webinar, is having people from different specialties talk about how they work together. And I think it's something that those places that haven't done that yet, I strongly encourage them to take that approach. We're going to talk about the resurgence. I mean, unless you're not watching the news at all, or you're not going to the hospital at all, you may know already that there's a tremendous resurgence. We're going to talk a little bit about that and what those trends indicate. And we're going to talk a lot about chest x-ray. I have my own bias here, which I will admit to up front, but we'll get to that. What can we do to drive POCUS adoption? What can we learn during this COVID pandemic that we can carry on over past this in the future? Looking at how well we can use POCUS to minimize infection risk in these kinds of situations, and then hopefully share a lot of questions with our audience and each other at the end. Let's talk first about the resurgence. And if we look at this graph that's coming here, you can see that spike up on the right that, you know, we had New York City be this incredible focus. We had Italy be this incredible focus, and certainly China. And then we thought we had things under control. Then one might argue we had Memorial Day. We could talk about some other potential reasons, but rather than necessarily talk about why it actually happened, we know it is happening. And Ray, you've got some pretty interesting statistics in your own location. I think it's important to note that the places that are spiking now are not typically the places that were spiking in the past. And what necessarily is different now than you realize in your institutions, different than where you were in kind of the first bump of this in the April-May timeframe. And Ray, maybe you could start that discussion for us.
Sure, I'd be happy to. It's been really interesting, and if you followed the news at all, you know, everybody was very scared who did not live in the Northeast back in April and May. And down here in Texas and other cities, we really battened down the hatches, and people did a good job, and we closed everything down. And we had, in our own institution, created a situation where we were able to handle at least 150 ventilator patients under normal circumstances without going to sort of a surge capacity. And so we did such a good job, I think, as a community that we actually did not peak with that many cases. And so I think it's fair to say that we took a lot of economic hit, but we kept the numbers low. But I'm not sure that our population really felt like there was a real problem. And so when we opened back up, we have observed a lot of economic activity. And so right now, I think we have about 4 times as many patients as we had at the peak of the surge. So at our facility, we're mainly a cardiac center. We're not the largest one in the medical center, but we have a situation where we went from about 4 to 6% positive test case, where our testing has been going up, but we went from a 4 to 6% test positive to over the last 3 weeks up to 14% in this last week. And as we opened up for business after Memorial Day, we had sort of a chronic 400 a day daily cases in the state of Texas, and yesterday we had 8,000 cases. So we've had a real resurgence, and we're projected to keep going upwards for the next 2 weeks. So what happened with the scare, the first time actually made us invest more in our point of care ultrasound. We viewed that as potentially very helpful and life-saving. We kind of laid the groundwork for how we were going to integrate with critical care medicine, really use point of care ultrasound, but then it kind of died down. We got to the point where we had very low numbers, maybe 6 COVID patients in the hospital, and today we have 91. So we are really doubling the amount of point of care ultrasound support that we have for the critical care doctors, and it's a good opportunity to move forward with what we had already started back in the spring.
So Chelsea, you know, Texas always likes to be bold and proud, and I trained at Texas at the best medical center in Texas, Parkland, of course, and we love having our battles with the people in Houston, of course. But Chelsea, what did you see? I mean, South Carolina is kind of rearing up again, being a nice participant in the Sun Belt. You know, didn't want to get left behind with this discussion. So what have you seen at your institution?
I've been so impressed with the preparedness that our emergency facilities have done to create the tents, the outdoor screenings, and all of this stuff. And we really had excellent numbers, and we're kind of jumping to get back to life as normal. And I think proms, trips to Myrtle Beach, and a bunch of socializing, I think it's hard to keep South Carolinians at home. And so with permission to go, they have gone and they have done. And yesterday we had a peak death rate of 24 individuals yesterday in the state of South Carolina. So we're going up. Yeah. And I'm thrilled to be getting more educational opportunities to my colleagues, like, hey, let's get you comfortable with the ultrasound if you're not yet. COVID's not going away. We really need these skills to try and help at any level we can.
I think one of the interesting things, and you guys can comment on this, and I'm impressed that both institutions took advantage of what was going on in the Northeast to get prepared, because there's so many that weren't. We weren't that affected. I know of a hospital, for instance, their way to get prepared for all the patients was buy another CT scanner so that they could be available for that. And I saw that purchase and went, I think we need to learn a little bit about lung ultrasound. But have you found in your colleagues that you communicate with around the country, have they shifted toward the preparedness with ultrasound? How many have stuck with the same dogma of chest x-rays and CT scans and not done ultrasound? And if so, why do you think they've held on so tightly to that? Anybody want to step up and guess? Or is everybody you guys know, because you're the in and smart crowd, are just using ultrasound?
I'll speak up for cardiology if you don't mind. I think that most cardiac doctors are focused on cardiac complications of COVID, and they're less focused on the lung exam. And I think there's not a lot of communication between critical care and cardiology sometimes. But so I think we're still stuck in the past in a lot of ways, from what I hear.
What do you think, Jose?
So let me try to make a statement that will resonate in the audience. Anybody in the world can learn lung ultrasonography in less than 1 hour. And more importantly, not only that, it actually will empower you even to go from being diagnostic to, in the future, even being for assisting for therapeutic interventions such as thoracentesis. So you become a practitioner enhancing safety. So the reality is the following. Everybody loves x-rays, because when you put the x-rays, the nurse can see the x-ray, the surgeon can see the x-ray, the clinician, everybody. When you do a lung ultrasound examination, sometimes it's not feasible for them to save the study. But as we move forward, I'm pretty sure we will be developing more robust, media service. And that actually, this is my collaboration with Dr. Steinbach. I mean, he is providing that support. We in the ICU and the emergency medicine world, we don't have all these resources that our echo labs have. With his progressive mindset, I'm predicting in the future, our electronic medical records, we have been starting working on that project. And now you will have the lung ultrasound, the cardiac ultrasound, and now you have such a robust diagnostic tool that is evident to everybody. So I think that's the drawback. It's like, that's the reason people love the swan guns in the past, to see the numbers there all the time, instead of having a snapshot with the cardiac ultrasound. So I think in the country, people have been reduced tremendously the amount of X-rays during COVID. The answer is yes. My good friend Noah Panebianco, for instance, in Philadelphia, emergency medicine physician, she implemented a handheld, driven algorithm there, and they have been using quite a bit. And I know that the amount of X-rays have been reduced significantly. However, this is the other thing. One thing is not order the X-ray. You say, okay, I can manage this patient and mechanical ventilatory support, been for a week, no X-ray, just following all the ventilator parameters. But with ultrasound, you still can have a daily evaluation, not exposing the patient to radiation. And not only that, you prone the patient, you can see your proning position has some patterns to say that very aeration. And you correlate that with the ABG, with your oxygenation. It just basically enhance and reinvigorate the physical exam in a daily basis without any consumables, in any patient.
So the resurgence that we've seen along the belt, obviously, I think there's some other changes that we've noticed and worth talking about. The difference in ages now that we see with people, there's been an interesting drop. I don't know, Chelsea, if you've seen the same at your institution, but candidly across the country, we noticed that it's the younger population that's involved now. Has that been your experience, Chelsea?
Yeah, I'm part of our community COVID screening outfits where we're going to different school campuses and free opportunities. People will drive. This morning we had people at 6 in the morning waiting for testing that began at 8 in the morning. So we managed to scan 495 patients for the coronavirus. And it is astounding the young people that we're screening and looking. And I know that the positives are coming up of all ages at approximately 14 to 16% positive for these, well enough to be in their community, in the vehicle with their family. And when we started these community screening clinics, I believe they've been going on for about 8 weeks now, we were having an estimated positive about 9 to 10%. So our percentages have jumped a lot. One thing, if it's okay, I'd like to jump back to what Jose was making comments and compliment, Jose, your foresight about the ultrasound not having the charisma as the X-ray does historically, because you can't click and open it. Once it's done, everybody can see it. And you're right on. It's coming in our hospital system. If I put an order in for my ultrasound, it actually will go through my handheld, be held through a middleware, and show up on PACS with the complement of my report on it. That is documented through our EMR. So it is so beautiful. It is coming. I think it's just going to depend on your health organization, how quickly it comes, but it's available now. It's pretty awesome.
Yeah, it's one of the things that we focused a lot on, in our group, is actually making that available, because sharing the image is important. I worked with a large group of cardiologists, and you would think that the only organ in the entire body is the heart, and because they don't wander from that. But the interesting thing is, if you get into heart failure, it's not your heart that everybody keeps complaining they're short of breath. It's their lungs, and we know the overlaps there. So Ray, we're going to count on you to teach all of the cardiologists across the country to learn lung ultrasound, so that when they see patients with congestive heart failure, they don't need to go to the lab and get a BNP. They can just pull out the ultrasound from their pocket and look at their lungs. So chest X-ray, Jose, I think you share my feelings. If I could wear a T-shirt, I would say I would love to see death to the chest X-ray, because there almost isn't anything, I personally think, that you can't get out of lung ultrasound that you need to get from a chest X-ray. What are your feelings about that, Jose?
A couple of years ago, I have an invite to a town hall meeting within the SCCM. By the way, I'm very active in the society, and we kind of try to educate as much as we can. And the person who was debating with me is one of the most experienced surgical intensivists in the United States. And actually, he was one of my attendants in critical care. And there was this question that is very hard to answer, but I will be absolutely sincere right now. He said, show me that you can replace your stethoscope with the ultrasound. Don't tell me you're doing both. It's just replacing it. And then I will tell you, so far, I can replace it. The answer is yes, with one exception. I still do not have the ability to diagnose bronchospasm with the ultrasound, wheezing. But I think at the pace we have been building the research, the data, we're getting there. And there is one last step, which is to demonstrate more consistently that the safety is enhanced. And for instance, I published a study 2 years ago showing 0% pneumothorax rate when you're doing real-time ultrasound thoracentesis or thoracostomy tissue placement versus marking or doing blind. So I think we're getting there. To go back to your questions, how we can say enough is enough, and we're not there yet. I think we need to, it is our responsibility to build more evidence, but I have seen the opposite. I have seen now some legal claims because ultrasound was not utilized in the AD when patients were admitted to the AD for the evaluation. So we went from nothing to be a complementary tool, and is transitioning to the tool that will be the standard of care for rapid assessment of clinical conditions.
Yeah, my favorite tool I want to see here, and then I'm going to have Chris pop up this ultrasound image, and you guys can talk about. I want to pop up on the ordering sheet that if you order a chest X-ray, for there to be a pop-up said, "Did you do a lung ultrasound yet?" That's what I want. Who wants to tell us what we're looking at here?
I'm happy to jump in. I love this clip because it's so beautiful and obvious for me, even though I've not had POCUS in my profession for years and years. What we're looking at is the coalescing nerve B lines that are actually growing together, which is a sign of fluid in the lungs. And I like to think about ultrasound, to break it down and make it simple for new ultrasonographers or established ones. Air is a nightmare. Air is always a nightmare. So when we think about a normal lung, we're going to see air. So if you want to see anything, you should be hoping to see artifact. So when we see these big sort of flashlight beams of light penetrating the whole screen in between our rib shadows, you got to be thinking fluid. And yes, I agree once again with Jose's comments earlier about lungs being really complicated on ultrasound and daunting for a lot of physicians. But to teach it in an hour is really truthful if you can break it down and grab one concept at a time. Lung ultrasound is very reasonable. I love it in urgent care because I can roll out a pneumothorax in a kid who flipped their four-wheeler before they go to the peds trauma service. And starting with, is there a lung sliding? You know, pneumothorax, no pneumothorax. That's not intimidating at all for someone with my background. And then to take it one step further, okay, I'm good with looking at the pleural lungs. Let's go to the next step. Okay, they sound wet, maybe on auscultation. So I'm going to do ultrasound. Is it focal? Is it diffuse? Can I get some sense in my limited, I don't have labs except a CBC and a BMAT at urgent care, flu swabs, little basic stuff. So if I'm worried about a patient lung exam, findings are abnormal, do I want to sort of jump on a treatment for CHF or maybe a focal pneumonia? Well, ultrasound helps me determine that. And if they're not stable enough to go to the x-ray department down the hall, I can keep them on the monitor, keep them in the bed, do lung ultrasound while the ambulance is coming to take them to a higher level of care. It's awesome.
So,
I like breaking that down one at a time.
B lines, I tell people, B lines, as Chelsea was saying, Dr. Bergen was saying, B lines are bad, with one exception. Again, B for bad, one exception. The exception is if you suspect a pneumothorax and you are seeing B lines, that's actually good for you because you are able to see B lines. It means that the ultrasound beam has passed the pleural space, and it passed the pleural space is against pneumothorax. I received a call from a radiologist saying, you put a line and then you produce a pneumothorax in the x-ray. I say, no, that's not possible. I have an ultrasound on top of the chest of the patient. I'm seeing B lines. You're wrong. You can probably do a CT. I'm not gonna order it because I don't want to expose radiation, but you're fine, you do it. Dr. Diaz Gomez, you're not, no. If he put that in the interpretation, that's something. So that's the reason we need to evolve and that have those images so I can defend myself that actually was right. So B lines are bad except when you suspect pneumothorax. It's good to see. I prefer a B line that dealing with a pneumothorax that I have to treat with an invasive procedure. But I wanted to share that.
That's beautiful. Thank you.
That's the little pearl of the day. So the good news is you don't have a pneumothorax. The bad news is you're in florid heart failure.
COVID.
It's the good news, bad news story there, right, Jose?
Yeah, now, but let me finish this. So as you notice, I have an accent, okay? Yes, I'm Hispanic.
Really?
I'm from Colombia, of course, yeah. So when you have the A lines, you know, the A lines, so I tell people, the A lines are good. They are your amigas, A lines, amigas. They are your friends, with one exception. You are suspecting pneumothorax. What about that? Then you're done. You want to see A lines, but if you are seeing A lines and suspecting pneumothorax, be concerned. So I use that way. That's the way I teach A and B lines.
Yeah, but see, the problem is you've got three really good doctors here who have never caused a pneumothorax in their entire career. So we've never seen one. So we wouldn't even actually know what you're talking about. I think it's interesting. And I think I would love to see us over time really do something with getting rid of chest x-rays, because it's still an incredibly common procedure done. And we'll look to you guys to actually help kind of get rid of that. So when you think about this and the COVID resurgence and let's say moving from chest x-rays and is there any other features of point of care ultrasound in this group that you might think about that's helpful? You know, Ray, you're a cardiologist. You know, it sounds like you've actually have some interest in looking at something other than the heart, but how has the COVID situation and you as a cardiologist actually seen some differences in this patient population?
Well, what I've seen is that the critical care doctors of pulmonary anesthesia doing critical care often feel fairly comfortable about their patients where maybe they already have a CT. They know they've got COVID, but the patient's hemodynamically unstable, or they have other potential cardiac COVID complications. And so I do think that the lung exam is very useful. And so what we've been called on mainly is to rule out cardiac causes of different things, you know. And so I think if you're learning the lung exam, it's just as easy to get familiar with getting those basic, you know, shock exam cardiac images to rule out, you know, these patients that have heart failure, preserved ejection fraction, they're volume depleted, or they can still have pericardial effusions or heart failure, reduced ejection fraction, screen for valve disease, and volume status. That can be done very quickly. And so I think you need to do both. And what I would say too is that when you're learning this skill, and I think cardiac of the heart's a little trickier because of all the structural heart disease that you can have, but I'd say it's like a visual language. I want to get to the point where I feel that I'm trying to teach my trainees in echocardiography where I can like look at an image and just instantly know what's there. And I think with lung that you can do that. I want to get to be like Jose and like Chelsea, where I just look at it and go, you know, if that patient doesn't have COVID, I'm just not gonna, I know that they've got it. You want to verify everything. But I think what I'm looking forward to, if there's any silver lining to this is a population where we do have many cases where there's multimodality imaging. So they're getting a CT, they're getting a chest x-ray. Do that ultrasound and compare so that you do have cross comparison with other modalities. This is important. You know, I spent years involved in lab accreditation. And so I think if you're going to undertake any kind of imaging, you need to have some sort of a QI program in place where people are trained, but also you need to check yourself. And for example, with this potential pneumothorax, I think that would have been a great opportunity for the radiologist to have looked at the ultrasound exam. Why was it that he diagnosed a CT scan? And then it can go the other way around. It's like, if I'm a new learner, am I looking at the lung exam? I'd kind of like to see the extent on a comprehensive exam, like on a CT, and compare that with my ultrasound images. And that's the beauty of the PACS systems and the electronic health system that Chelsea talked about. I mean, that's invaluable if you can like pull those images up and do that comparison and then kind of document it. And you can sort of, what we want to do here is work out a QI program where we can say, okay, this person knows what they're doing. And so we trust them, you know, their work. And so that's, and I have one other little question too to Chelsea. I'm really intrigued with this idea that you're scanning, you're out there in the community looking at patients that are symptomatic and doing the PCR testing. And so are you also scanning their lungs too, the symptomatic ones? Because, you know, that might be a really good way to, you know, isolate those patients early if they have abnormal lung findings before their results are back. So
I love that notion. And I actually have done the ultrasound in our clinic setting when we are just doing literally like the drive-through testing and helping manage that. I'm not pulling patients out of vehicles to scan them. They are grossly appearing stable at that point in time. But it actually was really nice having the probe today with me in my purse, just in case something came up. I could have scanned them. Mm-hmm. And I'll venture to shift the conversation a little bit back to maybe what John was touching on earlier. If we're looking at different applications for a point of care ultrasound in the midst of COVID, I love the notion of in urgent care, I get to scan soft tissue for infection. Is it just cellulitis or is there a pocket of fluid? If there is, I can assume there's an abscess I maybe can't feel for sure. And I'm going to up my A game by doing an incision and drainage with it. And if it looks complicated beyond scope of my practice for follow-up, then I also am charged with giving the patient that next step in education. You know what, this looks like more than what I'm going to be able to take care of today with, you know, natural progressive healing. I'm going to set you up with a general surgeon to follow up with. Mm-hmm. And I think at the beginning of our coronavirus pandemic, people were afraid to go to the doctor. Our volumes dropped substantially. We closed some of our clinics for a while until people were going to start needing us again. And I say that in a perceptive perspective. I don't think that our value went away, but people really don't want to come to the doctor when they're terrified.
Perfect setting for the next slide. And we start asking ourselves the question, why would someone not want to go to the doctor? And maybe they don't want to go to the doctor because this is what they're greeted with. It's not exactly this overwhelming feeling of like, wow, this is welcoming, come here, when you're greeted with the PPE issues that are here. But it's important to know that handheld ultrasound devices actually are perfect in this situation. So I think you guys should talk a little bit about that and how, for instance, we talked a little bit about this before, Ray, and how generally in the past, you know, cardiologists want to hold on to their own echoes, but now in this new world, and ASE has said this, now we think it's actually better now that we've got some expertise that if you're going to put on PPE and you're going to see patients that are high risk, maybe we should limit the number of times people go in to do different exams. You guys want to talk about this and your favorite new outfit that everybody's wearing to work these days?
Yeah, I'm happy to address that. I mean, the first round of the COVID pandemic, we didn't have enough PPE. It was a real problem. And so when the American Society of Echocardiography wrote their guidelines to document on addressing patients with PPE and the whole issue of disinfecting a cart, for example, after it goes into a unit where there's aerosolization, it can be a big process. You need to, you need to drape the console and the screen, and the person doing the scan dons all the PPE equipment and then does the scan, and then you roll it out. You've got to, wipe everything down. You really have to make sure you're not going to contaminate the yellow zone outside of the room. And so the recommendation is, well, maybe if handhelds available and this system can be isolated just in the way that you showed in your picture there, and it can be handed to the critical care doctor or whoever's already in the room, then you can save on PPE. But more importantly, our sonographers get a lot of exposure. I mean, they're going around, and so the more we can limit their contact, the better, because this is kind of, you're in it for the long run. So if we really need to get a sonographer in there and do a full cardiac exam, we'll do it. But if the critical care doctor or cardiologist, who is ever starting a line, can go ahead and get a pretty good enough exam, screen for those things that I mentioned before, it can be very useful. And the other issue we've had really with our infection control people in the hospital, even with that device, are the people using it fully trained in, not only preventing respiratory infection spread, disinfecting it, treating it very carefully, having all the equipment there available, and not just carrying it around in your pocket. And also their bloodborne pathogens are also important. So we've got at each unit, we've got a cart with all the needed supplies plus the unit. So it's readily available, but people don't have to go hunting down stuff to make sure it stays disinfected.
So this leads me to my next point, which I want to do with you. So what do you think, Jose? We got a monitor in every room. We've got oxygen in every room. Should we have a handheld ultrasound device in every critical care room so that we don't have to move it from bed to bed? They're getting to the point now where they're certainly affordable enough to do that. What do you think?
You nailed it down. I think you probably made the most important questions in a time for crisis management. All the response by the critical care team and the hospital teams across the board depends. The first call you have to make is to count on your supply chain. What kind of resources I have? So the answer is very, very simple. If you have the resources, the answer is yes. You should have it in every single room. I have the luxury here to have such a strong leader, Dr. Steinbach, that he will tell you how many he was able to roll out in a matter of days. So at least if you are able to do that, at least I can tell you that will empower the clinician and even the nurses. We have empowered nurses, because remember that the nurses will be reassessing the patient and our assignment is one-to-one. So even I have taught nurses even how to hold the probe when I even seen my patient that is an ECMO and they're holding a subcostal view and able to see where the cannula is, or even try to see if there are any thrombus in the veins, etc. So the answer is yes, that's the ideal situation. The problem is the resourcefulness, but I think as the technology has been more available, across the country, I think more people are seeing the utility. And not only that, at least in my case, I have been able to done this, demonstrating the value of having more accurate diagnosis from the beginning once the patient is having any clinical condition, instead of waiting for later on to just have a CT 2 or 3 days later. So you are diagnosing the right disease in a more timely fashion. So the answer is yes. That's probably will be the highest impact in point of care across the board, having the handheld devices at the bedside.
So one of our participants asked that question. Can you give us an idea of scale? How many ICU beds per POCUS or ED bays per POCUS? And obviously, as you say, it's resource-based, but, I think it's still a matter of reframing our thinking. You guys participate in one of America's greatest heart hospitals. And if you walk down into the cath lab and they're doing a procedure, they're throwing away $2,000 wires after using them once in a procedure all day long. Yet you could spend the same $2,000 on a handheld ultrasound device that could be in the ICU bed next to your patient, evaluating people for years. And so I think it's a matter of kind of reframing our thinking. It's obviously not an apples to apples comparison, but when you start thinking about the applicability of both physicians and nurses using ultrasound at the bedside, you bring this up. I think we're then going to see the power of ultrasound and what it can actually do in changing the way we manage patients. So maybe, Ray, you could walk down the cath lab and ask them to trade for a little while up with the guys in the ICU. What do you think?
Well, I think things have changed quite rapidly. I mean, the price point for these devices has dropped quite a bit. We've had these things for many years, and they've come in at each device being in the tens of thousands of dollars, and that you're going to keep it around for quite a while. So the technology's changed quite a bit. I mean, it's possible to go out and get these things retail. One of my fellows that just we interviewed last year from Washington. She's saved up her money and bought one off, the internet, and you can do that. But I think the problem is having consistency, that people are trained and that, they're kind of plugged in. And then there's the infection control stuff. I think it can be integrated. An issue too is the variability in the imaging device. Are people using their personal phone, or is there a monitor you can plug in that's in the room? That would be a nice thing to have. So I think that's could evolve. We have hundreds of beds between our surgical recovery intensive care units and the emergency room just in this one hospital. But there's some counties, there's like 4 counties in West Texas, and between the 4 of them only have 4 ICU beds. So it's just, they should have one in every room. But we may not, that would be a lot of technology to deploy, rapidly at our place. But I think we've taken a step in that direction, hopefully.
We've seen a lot of protocols evolve, and Chelsea, we're going to put one up here. We're interested in your comments. This came from the Italians, and it's a great protocol, adapted by some team of Royal Berkshire. We actually met with just recently, has really adopted it well. But this is a protocol that the Italians did on how they would use ultrasound, and we have one of our participants asked the question about monitoring patients either in the home. Do you have them come back in for ultrasounds? Do you have them have pulse oximetry? But can you kind of walk through this? Does this match with what you guys are doing? If so, I think you could endorse it. It would be great for people to follow. If not, do you have any other alternatives to this as a protocol people can use around the country if they're not familiar with having a really good protocol in place on how to use lung ultrasound?
I'm fascinated by the happy hypoxic comment that has been floating around South Carolina, and when do you pull the trigger or not? And because I'm ambulatory medicine, I'm going to defer to Dr. Jose, because I'm super excited to know what he has to say.
So my only criticism, we have we created the document here in our institution. It's called the best practice. And once again, I'm very respectful with the Italians. By the way, one of my previous mentors is Gabriel Villa. He's one of the international leaders in the field, trained by, he's a very close collaborator with Giovanni Volpicelli. And those guys have published extensively. But I need to say this. In our protocol, and I'm not seeing in the one here, is the symptom of dyspnea. Think about it. Think that you are in any, let me mention this, Rwanda, because there is a study that was done there with Dan Talmor, who was one of my my mentors in Boston. And I will tell you, they started basically that investigation to challenge the classic Berlin classification for ARDS. It's called the Kaggle, classification. It's a modification of the Berlin, classification. And the bottom line is to get rid of the X-ray, do an ultrasound and pulse oximetry. Here at Baylor St. Luke's, under this pandemic, we put the pulse oximetry, but with the symptom of dyspnea. So if somebody's dyspneic and you're able to do a lung ultrasound, that would be a good first step. So dyspnea for lung ultrasound, are B lines, yes or no? If there are B lines, most likely, when you put the pulse oximeter, most likely, because there is correlation, that pulse oximeter will be lower. And it is possible that you do an X-ray, the X-ray might be looking normal because the sensitivity of the ultrasonography is higher than the X-ray. So that will be the only modification I will do. I'm fine with those parameters for pulse oximetry, but please do not ignore the dyspnea. And as the patient is progressing, more dyspnea means I need to see more B lines. And then I'm getting prepared to either upgrade this patient for high flow nasal cannula or even just going for intubation or the helmet. So I can share with you later our algorithm, how we provide oxygen therapy in the institution, but we think the dyspnea is an important symptom. I didn't see dyspnea in the Italian algorithm.
Do you do walking trials? Now, I know, Chelsea, they walk to you, so you do them automatically when they come to your clinic, but do you do walking trials with your patients that say may not have dyspnea at rest, but then you walk them?
No. Most of them we have been in the, because think about it. Even we created flows inside the hospital, how we're gonna transfer this patient. You're not gonna put this patient walk around and you don't know they are PUIs or they will be tested. So you don't know the disease. You have to be respectful. So I think it's enough with the symptom at rest, and then pulse oximetry and the ultrasonography. With those three, you should be able to have an initial triage.
So your triage then, to clarify, is if they're not short of breath or dyspneic and they have a good lung ultrasound, see ya.
The negative predictive value of lung ultrasonography in that setting is pretty strong. And I can argue with anybody. I will tell you, it depends what walking test, how fast you're gonna be walking, you know? Are you the condition? Do you have a knee problem, an ankle problem? I'm not sure about that. They just basically bringing that from pulmonary medicine. And I do not believe that needs to be like the standard way to approach patients.
So how much of the combined cardiac pulmonary? So, you know, we always talk about what the COVID involvement is here. Does everyone that has lung involvement, do they need an echo? Or can we use that selectively? Should Chelsea be doing more echoes out there in her outpatient group if she's got those people, or are they only reserved for those people that actually end up in the hospital?
So great question. I had a patient maybe a week and a half ago, came in short of breath, no chest pain, and I have to be very clear, and I ask 100 times if they have chest pain, because of course I don't have a troponin. I'm ambulatory office. So in the midst of this 4 weeks of building, kind of short of breath, the patient thought he was too old to get AFib, even though his siblings and daughter had it. Well, his pulse was not regular, and neither was the auscultation of his chest. And I stuck the probe on him, and I found diffuse B lines. So I'm thinking, okay, CHF, secondary to AFib, but he had a history of PE. So I think the ultrasound was beautiful because, yes, I could see his ventricle quivering. I don't do ejection measurements, but I knew that he was probably having some heart failure, creating the diffuse fluid, pulmonary edema on his ultrasound for the lungs. And then it just really sealed the deal. Yes, you've been having this for 4 weeks, but today's the day you decided it was too much dyspnea, and today's the day you're going to go to the hospital. He ended up having a pulmonary embolism with new AFib and CHF, and it could have gone, you know, in that order. But I was so thankful to have that ultrasound so I could really help solidify in his mind that yes, he did deserve a higher level of care despite everybody else that might have the coronavirus, because he decided there were other sicker people who didn't need to go. And the ultrasound really, I think, helped seal the deal. Yes, sir, you do need to go. Yeah.
What do you think, Ray? Who needs an echo?
I think if you're gonna, it's just such a helpful study. If nothing else, just if you're gonna be doing handheld and you're looking at the lungs, you have to really look at the heart, because getting back to the chest x-ray, for example, you've got the patient that's short of breath, they get a chest x-ray, the heart's enlarged. I've had several cases over the year where the patient's given the diagnosis of heart failure based on the chest x-ray, but they actually have a massive chronic pericardial effusion, and they've been made unstable by giving diuretics. These can be malignant, they can be related to infection, other things. The other thing is there's very classic findings of pulmonary emboli. Now, that can be a cause of shortness of breath. People with COVID have increased rates of pulmonary emboli. So I think it's nice to kind of get that look. You don't have to be kind of make the RV looks normal, it looks big and abnormal. It can be, it can be a starting point for, ruling out a PE, getting an echo, you sort of screen for those things.
So question for you, all of you. You guys are advocates, clearly, and you speak passionately about the value proposition and quite convincing. And I've already learned through this webinar, I don't want to argue with Jose because I think he'll be very quick to argue back. It'd be a lot of fun. I actually would love to do surgery with Jose on the other side of the screen. It would be a whole lot of fun because we would know he would be the cause of hypotension, not me. But I think the question for all three of you is what's inhibiting the adoption? What is keeping people from jumping on board and being the believers that you guys are? How do we accelerate that across the country? How do we take the lessons that you've learned, that you guys have led in your practice, and rapidly scale them around the country? What are your suggestions on how we do that?
I mean, I'll jump in. I feel very strongly that we're suffering from the death of the physical exam. When you have so much throughput through the system, you know, people have short amount of time to see the patient. It's just so much easier to order a test than actually examine the patient. And so with point of care ultrasound, you're actually asking them to take their shirt off and, oh my God, you know, actually do an extended exam. So you've really got to have somebody who wants to take care of the patient and figure out what's wrong with them, and not just order a test that gets done after they've left the room. I think that's the main thing. And the price point coming down is going to really help. The fact that it's, you know, it hasn't been that long that it was available on smartphone devices. I think that the technology has gotten to the point where it can be adapted more, but we just have to have people that are interested in examining the patient. Some people aren't.
Chelsea, your thoughts?
Oh, I got a lot of thoughts. Thanks for asking. You know, one of the obstacles that I have personally had to overcome to really incorporate bedside ultrasound into my practice in urgent care has been knowing that some ultrasound applications are harder to learn than others. And what might be challenging and daunting for me might actually be very easy for Ray, because he lives and breathes heart. And the lungs that are so natural for Jose, well, it becomes easier when I've actually had my own patient that I've had to do ultrasound on and say, oh, he doesn't have a pneumothorax. I feel so much better about sending him to the peds trauma, you know, attending. Like, that's awesome. As I have tried to teach it enough to myself to be able to share it with others and get them excited and like enable, well, I should say empower them to feel like you can learn and do this too. It's just going to make you a better physician. A, the patients love it. B, it makes you more accurate with nearly any decision. If you follow the evidence-based medicine, it's fantastic. But back to the hump and getting over it, you're really taking a 360-degree look of a person in a full color world, 3-dimensional, and you're shrinking it down into a 2-dimensional, 256 shades of gray. And then you're trying to identify what's going on. So if you can give yourself a little bit of grace and slack and understand that it's a learning curve, there are patterns. Ultrasound is pattern learning. And once you can learn the patterns and what pattern goes with what and what the indications are to look for that pattern and what the implications are when you see that pattern, it's a very smooth, beautiful learning process. But it's an investment of time, and I cannot speak more to the power of good mentors and really having a Q&A process in your training system network that works for you, whether it's a mentor in your hospital or someone outside that's watching you remotely. Mentorship is huge, and practice.
Oh, I'm glad you mentioned that, Chelsea, because as you were talking, I thought, you know, that is a huge obstacle. And I want to learn the lung, but our pulmonary doctors didn't have the resource to do lung ultrasound. And so it's not really being done. And so it has to be done. In our institution, also, the anesthesia and critical care doctors have an opportunity to rotate in the echo lab for a couple of weeks and just do cardiac scanning. And so that's where you kind of overcome the hump. But if you're already out in practice, there's very few mentorship opportunities like that. And it's just hard to do it online, or, you know, I would think with confidence.
So we got a question out here. How have you guys been able to convince the administration on the importance of lung ultrasound versus chest x-ray to get them to purchase the device? And here's one of the things that I'll interject. I think one of the real differences is, first of all, when we listen to the lungs, you got to tell patients to be quiet. And so we listen there, and when you use lung ultrasound and look at, they can keep talking. So if you look at an efficiency of an exam, you can be examining their lungs with ultrasound while they're giving you a history. And actually, it can be a much more efficient way to actually evaluate a patient. But I think we do have to bring it back. And I think one of the things that's been special about ultrasound is that the computer has taken us away from the patient. Ultrasound brings us back. And most of us got into medicine to be with patients and to answer their questions and give them an answer. And I think ultrasound is that connection back. And what's really interesting about the device to the phone to us, you're actually creating, and it's a little bit touchy-feely for a surgeon. Jose, don't laugh at me. But it's almost like you bring that umbilical cord back. You know, this is us attaching to each other and creating that bond that is so important in medicine. And so how do we bring that, as well as the information that's out there in the data about how much better ultrasound is than chest x-ray, to our administrators, so they're willing to invest actually what's now a very modest amount of money, which you guys are clearly demonstrating is actually better medicine. Any suggestions for our audience?
What does administration not like about a good customer satisfaction survey? Ultrasound improves patient satisfaction. Patients love it because A, it's more time with us, and you can show them the screen like, hey, this is your lungs. When I'm seeing these little A lines, that's awesome. A for awesome. The B lines are bad, but I don't see any, so we're good. You don't have to worry about that. Administration has got to smile on those relationships that really help our Press Any scores, or whatever score makes you, well, shows how good you really are.
Jose, any ideas?
Yes, so actually from last question, my only obstacle has been time. Because you think about it, when we do this, we need to do the exam and interpret. So that's the only obstacle I find. And the answer to your current question is one, storytelling. The administrators need to listen that beautiful story when you change a patient outcome, when you actually were able to even deliver more compassionate care. Not all the time is about even, for instance, I have cases where I was able to use ultrasound to alleviate large pleural effusion, treat it, decrease the dyspnea, consult palliative medicine, and instead of bringing the patient to the ICU, the patient will go to the floor, gathering with her family, and go with different goals of care. So you need to have very clear how you're gonna sell this to administration with good stories. And if you want to go to the next step, is showing the cost effectiveness. Big time. You can demonstrate even lower lengths of stay. Hopefully by next year I can have finalized a publication I have on patients with liver transplantation that I did in the past. And then you will see how you recognize these pleural effusions ahead of time. You can actually move this patient faster and being in the hospital. So that will be my two strategies: storytelling, and try to find at least some gain from the resources standpoint, that you are using your resources, making sure that the patient actually are moving faster inside the system with more efficiency.
I think that, and I totally agree with both of you. I think the goal of this is to make our patients happy and the doctors happy, and the system more cost effective. And I think ultrasound delivers on all three. I think it's critically important that we tell those stories and candidly invite the administrators down to the emergency room or into the ICU and actually show them the difference. It doesn't take much to see the difference between the look on the face of a patient that's waiting to get an x-ray versus the one that's already got the answer and is going out the door. If you don't see the difference between those two things, you probably shouldn't be an administrator in a hospital and to know the difference. One other question that's here, and I've miraculously on and off the mute button. We have a veterinarian who's actually topped in and said she's using ultrasound now pretty extensively. We have many dogs in our house, and they've done a pretty good job of staying quiet. But for the veterinarians that are out there, it's actually a great device for them as well. And I appreciate the fact that our veterinary friends are here joining us on this, because candidly, it's incredibly effective for them as well. Well, we're getting near the end of the hour, and I want to thank all three of you. We brought some really important messages home. I think we discussed the resurgence and how you guys have adapted to that incredibly well. You're joining me in my mission for Death to the Chest X-ray, which is great. I'll be beginning that club. Maybe I'll start a blog, and we'll all be part of that. I think we've learned kind of in the algorithms that you guys are using, really effective ones. And we've got Captain Dyspnea here, who is on the dyspnea bandwagon now, to tell us that that's such a key part of this. And using lung ultrasound together with those two, an incredibly effective tool. And I think we've also seen a demonstration in all three environments, physicians who have adapted their skills that they didn't start with, who now have, and effectively using them with ultrasound. I think the cost of the devices have been brought up many, many times here and what a difference it makes. And I think listen, we use stethoscopes a lot more often because they're in our pockets. You will use ultrasound a lot more often if you have it in your pocket. And I think the challenge is now, don't rely on a cart that's in a corner, rely on the probe that's in your pocket. And if you begin to think that way, you will learn it faster, you'll deliver better care. And I think Jose has shared a great example of that is the case. And then I'll leave you with the fact that we've got 3 people who are very willing to be followed up with. I think we'll share their contact information with you. They have great advice they've shared with all of us, and they can be great mentors to all of you. They're willing to sit at home 24 hours a day and answer your questions. They'll share with you their home phone numbers and their beepers. Well, maybe not all of those things, but they have been really great with us tonight. And so please stay in touch with us at Butterfly. We're happy to share information. Follow these 3 physicians closely. They are leaders, if you will, across the practice of medicine. They're incredible examples of what physicians should be and what they should aspire to be. And I want to thank all 3 of you for being such tremendous mentors and examples for all of us to follow.
Thank you.
Thank you, John.
And please don't forget me, you need an anesthesiologist later on.
You got it. You got it.